Hi, my name is Priscilla Jones Sorne, and I'll be presenting to you a case study about depression or major depressive disorder. Depression is a mood disorder that causes a persistent feeling of sadness and loss of interest. It is also called major depressive disorder or clinical depression. A depressed person may have trouble doing normal day-to-day activities and sometimes may feel as if life isn't worth living. According to the 5th edition of Diagnostic and Statistical Manual of Mental Disorders, an individual must have 5 of the following symptoms, of which one must be a depressed mood or anhedonia, causing social or occupational impairment to be diagnosed with major depressive disorder. These two should be present for more than 2 weeks to be able to be diagnosed with clinical depression. Other symptoms include feelings of guilt or worthlessness, lack of energy, or feeling tired all the time as evidence of weakness and fatigue, poor concentration, difficulty thinking, focusing, and making decisions, appetite changes, there's an intentional weight change of 5% or more in a month, psychomotor retardation or agitation, a general slowdown of motor activity commonly accompanies depression, sleep disturbances like lack of sleep or oversleeping, suicidal thoughts like hopelessness and helplessness. The predisposing factors are multifactorial. Can be genetic, biological, psychosocial, pharmacological, or by gender. There is an unclear relationship between psychological stress, stressful life events, and depression onset. Some drugs may also affect the mental status. For example, medication includes antihypertensive, psychotropics, antiparkinsonian drugs, oral antidiabetics, steroids, and chemotherapeutic agents. The prevalence rate is almost double in women than in men. But the incidence of clinically significant depressive symptoms increases with advanced age, especially when associated with medical illness or institutionalization. What are the areas of the brain involved? First is the amygdala. Amygdala is part of a group of structures deep in the brain that's associated with emotions such as anger, pleasure, sorrow, fear, and sexual arousal. Activity in the amygdala is higher when a person is sad or clinically depressed, and this continues even after recovery from depression. This increase in activity may actually cause the amygdala to enlarge. Another is the basal ganglia. They are connected to and interact with structures that are closer to the brain's surface. Some studies have found shrinkage and other structural changes in the basal ganglia in people with depression. The last one is the hippocampus. It plays a key role in processing long-term memory. The interplay between the hippocampus and the amygdala might account for the adage, once bitten, twice shy. The hippocampus is smaller in some depressed people, and research suggests that ongoing exposure to stress hormones impairs the growth of neurons in this part of the brain. Pathophysiology. A monoamine theory involves lack of monoamine neurotransmitters such as serotonin, dopamine, and norepinephrine. Another theory is the abnormal hypothalamic and pituitary axis. There is increased cortisol, with decreased dexamethasone disturbance. It is also linked to growth hormones and thyroid hormones. Let's go now to our case study. Our patient is Ms. Sheila Adair, 40 years old female, living in Regina, Saskatchewan. She is living in her apartment alone, and her diagnosis is new onset depression. She has a comorbidity of diabetes, and she has recently moved to Canada and just started working. Her 2 daughters was left in the Philippines with her mother. To assess the patient, we can use therapeutic techniques like using open-ended questions. We can say, "I noticed that you still look tired. How have you been sleeping lately?" And the patient will then respond with, "I haven't been sleeping much lately. There are so many things on my mind, and sometimes I can't sleep at all. I feel tired all the time." Another therapeutic technique would be providing leads to the patient. The nurse can say, "Tell me about your concerns. How are you feeling right now? Tell me more about it." And the patient may respond, "No one really cares about me. I feel so alone." One of priority diagnosis is self-care deficit related to insomnia or oversleeping and preoccupation with thoughts as evidenced by altered sleep schedules and poor appearance, body odors, disheveled clothing. The treatment goal will be patient will improve sleep habits by instituting a set bedtime and wake time. A nursing intervention, setting up a specific and detailed eating, grooming, and dressing schedule can help the patient feel more motivated. Our evaluation, the goal met as evidenced by patient being well groomed every day and being able to sleep without interruption. Our expected outcome is the patient is able to follow through with activities and verbalize being able to sleep 6 to 8 hours a day. Another nursing diagnosis is hopelessness related to social isolation as evidenced by decreased affect and loss of interest in life. Our evaluation will be goal met as evidenced by patient's positive outlook in life and being able to use coping mechanism. Our expected outcome is patient is able to identify coping mechanisms to help her in times of feeling of hopelessness. Our treatment goal is patient will identify coping mechanisms to improve feelings of hopelessness. Our nursing intervention is assist the patient in remembering past coping mechanisms they have used that work or past interests that can help today. Journaling, music, dance, sports, traveling, being outside, and playing with a pet are a few examples. Pharmacological intervention. Antidepressants are being used, and selective serotonin reuptake inhibitors or SSRIs such as escitalopram, sertraline, fluoxetine, and paroxetine. When taking these medications, there are possible side effects that we can provide as a patient teaching. For example, the possible side effects include nausea and drowsiness, So we should take the medication with food and preferably at bedtime to reduce the nausea. And also take caution when taking the drug with other medications that increase the risk of bleeding, such as non-steroidal anti-inflammatory drugs or NSAIDs, aspirin, warfarin, and other blood thinners. The serotonin syndrome. Rarely an antidepressant can cause high levels of serotonin to accumulate in your body. Serotonin syndrome most often occurs when two medications that raise the level of serotonin are combined. These include, for example, other antidepressants, certain pain or headache medications, and the herbal supplement St. John's. Now we can discuss about community support resources for our patients. Number one is the counseling services provided by Catholic Family Services of Regina in McIntosh Street. The business line is 306-525-0521. They can also be reached through their website, Facebook, Twitter, and also through their email. The second is Depression and Anxiety Support Group provided by Caring Place Regina Incorporated at Osler Street. They can be contacted through the phone number 306-347-2273. They also have their own website, Facebook, Twitter, and email. The last one is social programs provided by Student Energy in Action for Regina Community Health Incorporated in Albert Street. And their phone number is 306-570-6208. So all these community support resources provide counseling and also other programs to help our depressed patients. And the last one is the crisis intervention resources. The first is Mobile Crisis Regina. It is for individuals or families who are in crisis. Typical issues addressed include child welfare, emergency, financial needs, mental health, counseling, substance abuse, domestic violence, and problems of gambling. Crisis workers prioritize requests for services based on urgency of the situation or the possible level of risk. The second is Helpline. The phone number is 811 and you're free to call. There is no long distance charges. When you call Helpline, you have the option to speak with a registered nurse or a mental health and addiction professional. If you choose to speak with a registered nurse, the nurse will assess your symptoms and provide you with the most appropriate health support or information. So here are my references for this presentation. This you can comment down for any questions, clarifications. This ends our case presentation. Thank you so much.